Ruxolitinib, as you mentioned, is now licensed in myelofibrosis, PV, and now in GVH. The most natural additional one is one that is undergoing phase 3 testing, which would be for patients with essential thrombocythemia that have failed hydroxyurea. And certainly in our current NCCN guidelines is considered one of the backup therapies as well. The ability to control the platelets, high counts, improve symptoms, decrease the risk of thrombosis and bleeding. It clearly has an impact on patients with MPN, MDS overlap syndromes. So in there is patients with chronic myelomonocytic leukemia, particularly if they're proliferative or have the JAK2 mutation, as well as other patients that are overlap patients with MDS but who have proliferative features. Ruxolitinib as a JAK2 inhibitor inhibits the erythropoietin pathway. So the development anemia is, I wouldn't even view it as a toxicity, it's really an on-target effect. And in fact, even the dosing of the drug, the half-life of JAK inhibitors has very much been balanced against that piece. All of that said, there is clearly a window to be able to walk through that optimizes the benefit of using the therapy while limiting the impact of anemia. First, we have learned that patients do end up compensating over time. So the anemia does tend to be front-loaded with some amount of recovery. Second, we have learned that there are certainly times that other agents may be used in combination with ruxolitinib if persistent anemia really extends beyond 3 to 6 months. If the erythropoietin level is suboptimal, supplemental erythropoietin sometimes can be beneficial, particularly if they have renal insufficiency. There have been trials that have shown that I and my colleagues have led with a combination of the androgen danazol that can be used along with ruxolitinib, and it's a fairly inexpensive, non-toxic agent that can be used with that. There have been studies at this recent ASH 2018 that looked at ruxolitinib combined with immunomodulatory drugs such as thalidomide for people in which significant anemia has been part. See, for the majority of patients, it's manageable with the issue of dosing as well as some patience, but for those that have difficult anemia, or let's say were transfusion dependent when they started ruxolitinib, the combination therapies as well as new clinical trials are of interest, with new agents in combination being tested with agents such as luspatercept and others that might impact anemia.